Welcome back to the deep dive. Today, we are really taking a plunge, getting into the weeds on one of the body's most critical systems.
Absolutely. It's the system that, literally keeps you from bleeding out from a simple paper cut. It's fundamental.
We're talking about how the body prevents blood loss, the incredible, almost choreographed processes of hemostasis and blood coagulation.
It's a fascinating cascade of events, constantly ready to spring into action the second there's a breach in your circulatory.
And our source material today, it's some really detailed excerpts from a comprehensive physiology text. So we're getting the proper biological mechanisms laid out for us.
Yeah, it gives us the blueprint, basically. And our mission, as always, is to unpack all that complexity. We want to move beyond just, surface knowledge.
Right, not just memorizing terms, but really understanding the insights, how these pieces fit together, the triggers, the feedback loops. It's like trying to grasp the body's own internal logic.
It really is like a precise choreography. We want to understand every step, every player, to get that deep, integrated understanding, the kind professionals in the field need.
Exactly. So whether you're brushing up, learning this for the first time, or just curious about how your body performs these miracles daily, you're in the right spot. Let's dive in.
Okay, so let's start with the main term, hemostasis. It's pretty straightforward. It just means preventing blood loss.
Stopping the bleeding. And the text breaks this down into four main mechanisms that kick in when a vessel gets damaged, right?
That's right, four pillars, you could say. And they happen in sequence, but they also overlap and support each other.
First up, the immediate reaction.
Vascular constriction. The blood vessel literally squeezes itself tighter to reduce flow, instantly.
Okay, makes sense. Step two.
Formation of a platelet plug. These tiny things rush in and form a temporary patch. Super important for small leaks.
Then comes the heavy hitter.
Right, the formation of a blood clot, which is proper coagulation. This builds a much stronger, more stable seal.
And finally, there's the long-term fix.
The eventual growth of fibrous tissue into that clot. So the temporary plug becomes a permanent repair integrated into the vessel wall.
Got it. So let's tackle that first responder. Vascular constriction. The text says this happens immediately after trauma.
Instantly. The smooth muscle cells within the wall of the damaged vessel contract forcefully.
And the obvious benefit is reducing blood flow out of that rupture. Less flow, less loss.
Exactly. It's the body's first, fastest way to stem the tide. And the text points to three main causes for this constriction happening.
Okay, what are they?
First, there's local myogenic spasm. This is the muscle directly reacting to the injury itself, like the physical damage makes it contract.
So the muscle just recoils from being damaged?
Pretty much. And the text suggests for smaller vessels, this direct muscle reaction might actually be the most important factor in that initial clamping down.
Okay, what else?
Then you have local autocoid factors. These are basically chemical signals released right at the site.
Released by what?
By the traumatized tissues themselves, by the damaged endothelial lining of the vessel, and, importantly, by the blood platelets that are already arriving on scene.
Ah, so platelets are involved even before they form the plug. I think the text mentioned thromboxane A2.
Yes, thromboxane A2, released by platelets, is a really potent vasoconstrictor. So chemical alarms are sounding from the damaged tissue and the first responders.
Okay, direct muscle reaction, chemical signals. What's the third trigger?
Nervous reflexes. Pain signals or other sensory impulses from the damaged area travel through the nervous system and can trigger reflex contractions in the vessel wall.
So it's a multi-pronged signal? The muscle itself, local chemicals, and the nervous system all yelling, "Contract!"
Right. And it makes sense, the text points out, that the more severe the trauma, generally the greater the degree of spasm. A bigger injury gets a stronger initial squeeze.
And this isn't just a quick twitch, is it? How long does it last?
It can last for quite a while, minutes, or according to the text, sometimes even hours.
And that duration is key, I imagine.
Absolutely critical. It buys precious time. Time for the next stages, the platelet plug formation, and the whole coagulation cascade, to actually get started and build a more stable defense. Without that initial slowdown, things could get out of hand quickly.
Okay, so constriction slows things down. But you still have a hole. The text mentioned these tiny, tiny breaks happen thousands of times a day in our capillaries. What seals those up?
That's precisely where the platelet plug comes in. It's the go-to mechanism for sealing those really small, everyday holes. And to get this, we need to look at platelets themselves.
Thrombocytes, right. The text describes them as these tiny little discs, really minuscule, 1 to 4 micrometers across.
Yeah, tiny. And they're not even full cells. They're fragments that bud off from massive cells in the bone marrow called megakaryocytes, like little pieces breaking off.
But there are tons of them. What's the normal count?
The text gives a range of 150,000 to 450,000 per microliter of blood. That's an enormous number floating around, ready to act.
And despite lacking a nucleus, they're packed with functional stuff, aren't they?
Amazingly so. The text lists quite a bit. They've got contractile proteins, actin, myosin, and something called thrombocytopenia. These are crucial for enabling the platelet to contract later on.
Okay, so they can squeeze. What else?
They have bits of endoplasmic reticulum and Golgi apparatus left over. This means they can still synthesize certain enzymes and, critically, store large amounts of calcium ions. Calcium is vital for clotting.
Right. Calcium keeps coming up.
They also have mitochondria for making energy ATP and ADP, and enzyme systems to synthesize prostaglandins, those local hormones involved in vascular reactions.
And they carry specific proteins needed later.
Yes, like fibrin stabilizing factor, which, as the name suggests, helps make the final fibrin clot really strong, and a growth factor, which stimulates endothelial cells, smooth muscle cells, and fibroblasts to grow, aiding in the long-term repair of the vessel wall.
Wow. So these tiny fragments are like circulating first aid kits with tools for contracting, signaling, energy, clotting reinforcement, and repair.
Pretty much. And their surface is key to their job. The text mentions a glycoprotein coat.
This coat is interesting. It repels normal endothelium.
Exactly. It prevents them from sticking where they shouldn't, keeps them flowing smoothly over healthy vessel lining.
Yeah, but when it hits damage, especially exposed collagen,
then its properties change. It causes the platelet to adhere strongly to that injured site, particularly to expose collagen fibers in the vessel wall beneath the endothelium.
like molecular Velcro that only sticks to the damaged spots.
A great analogy. And their cell membrane itself is rich in phospholipids. These phospholipids are absolutely essential because they provide the surface, the platform, on which many of the blood clotting reactions actually take place.
So platelets are designed to ignore the healthy, activate on the injured, provide a physical patch, and the chemical workbench for the next steps.
Precisely. And they have a limited lifespan, about 8 to 12 days according to the text. Their internal systems eventually run down.
Where do they go then?
They're mostly removed by macrophages, especially in the spleen. The text says more than half the body's platelets might actually be stored in the spleen, like a reserve force.
Interesting. Okay, so how does this activation lead to a plug? What happens when they stick?
The text describes some really rapid, dramatic changes. They contact the damaged surface, especially collagen.
And they change shape?
Yeah, they swell up, become irregular, and shoot out these sticky pseudopods like little arms reaching out. They become activated.
They contract, releasing their internal granules.
Yes, forcefully releasing those active factors we talked about, and they become incredibly sticky. They stick to the collagen, and crucially, they stick to von Willebrand factor, VWF.
Ah, VWF. What's its role again?
It's a protein found in plasma, also released by damaged endothelial cells. It leaks into the injured tissue, and the text explains it acts like a molecular bridge. It connects the collagen in the damaged wall to a specific receptor, GPIB, on the platelet surface.
So VWF is the essential glue linking the platelet to the injury site.
Exactly, it anchors them. And at the same time, these activated platelets start secreting large amounts of ADP, platelet activating factor, PAF, and they synthesize and release more thromboxane A2, TXA2.
Okay, and these chemicals then act on other nearby platelets.
Precisely. This is that positive feedback loop. TXA2, ADP, and PAF are signals that activate nearby, circulating platelets that haven't stuck yet.
Making them sticky?
Making them sticky,
Yeah.
causing them to adhere to the platelets that are already activated and stuck down. It creates aggregation.
So one platelet sticks, calls for backup. The backup sticks to the first one, calls for more backup. It builds up layer by layer.
Exactly, forming a growing mass, the platelet plug. The text notes that initially, this plug might be somewhat loose,
But for those tiny daily capillary breaks, it's often enough.
often completely sufficient to stop the bleeding on its own. It's the primary defense for that constant microdamage.
But for bigger holes, it needs reinforcement.
That's where the next stage, blood coagulation, comes in. As that process starts, fibrin threads begin to form. The text says these threads weave themselves through the platelet plug, attaching tightly to the platelets.
Like reinforcing bars in concrete, turning the loose plug into a solid, unyielding mass.
An excellent way to put it. And the text really drives home the importance of this platelet plugging for those countless tiny ruptures. It mentions platelets can even fuse with endothelial cells sometimes to help repair small gaps.
And it gives the example of petechiae,
Right. Those small pinpoint hemorrhages you see on the skin in people with very low platelet counts, thrombocytopenia, they're visible proof of the thousands of tiny vessel leaks that platelets normally seal instantly without us ever knowing. It really highlights their constant, essential work.
Okay, constriction bought time, the platelet plug patched the small stuff and laid a foundation. Now, for larger injuries or real stability, we need the third mechanism: blood clot formation, coagulation.
This is the really intricate part, the biochemical cascade that turns liquid blood into a gel-like clot. And it starts surprisingly fast.
How fast?
The text says within 15 to 20 seconds if the trauma is severe, maybe 1 to 2 minutes if it's minor.
What kicks it off? What are the triggers?
It's initiated by activator substances released from the traumatized vessel wall itself, from the activated platelets that are aggregating there, and also from blood proteins that stick to the damaged wall. Basically, signals from the injury site.
The text mentions a figure showing the sequence. Severed vessel, platelet aggregation, fibrin appears, fibrin clot forms, then clot retraction.
Yeah, it's a visual progression. And the text estimates that if the hole isn't too big, the entire opening can be plugged by a clot within about 3 to 6 minutes.
And then the clot itself changes, retracts.
Right. Over the next 20 to 60 minutes, the clot contracts and pulls the vessel edges together. But before we get to retraction, let's focus on how the clot actually forms.
The text emphasizes this balance, right, between procoagulants and anticoagulants.
Exactly. Normally, in flowing blood, the anticoagulants, which inhibit clotting, dominate, keeping blood liquid. But trauma activates the procoagulants, which promote clotting locally, tipping the balance at the injury site towards clot formation.
And there are apparently dozens of these factors involved, over 50.
Yeah, it's a complex interplay.
Yeah.
But the text helpfully simplifies the core process of forming the clot itself into 3 essential steps. This is key for understanding the final common pathway.
Okay, step 1.
Formation of prothrombin activator. This is itself a complex cascade involving many factors, triggered by the vessel damage or blood trauma. The text says this is usually the slowest, rate-limiting step in the whole process.
So making this prothrombin activator enzyme complex is the bottleneck.
Generally, yes. Once you have that, the next steps are faster.
Step 2 is?
The prothrombin activator complex, in the presence of sufficient calcium ions, there's calcium, again, catalyzes the conversion of prothrombin into thrombin.
Prothrombin is the inactive precursor. Thrombin is the active enzyme.
Precisely. Thrombin is the star player in the final act.
And step 3?
Thrombin acts as an enzyme to convert fibrinogen, a soluble plasma protein, into fibrin monomers. These monomers then automatically link together to form long, insoluble fibrin fibers.
And these fibers are the actual meshwork of the clot?
Exactly. They trap blood cells, platelets, plasma, forming the physical structure of the clot. So the bottleneck is making prothrombin activator. After that, thrombin forms quickly, and fibrin forms quickly from fibrinogen. Let's dive a bit deeper into those key players. First, that conversion, prothrombin to thrombin.
Driven by the prothrombin activator complex plus calcium.
Right. And remember the platelets. The text mentions a neat trick. A lot of the prothrombin circulating in the blood actually attaches to specific receptors on the platelets that are already stuck to the damaged tissue.
Ah, bringing the substrate right to where the enzyme prothrombin activator is being formed. Very efficient.
It's all about localization. Now, prothrombin itself is a plasma protein, an alpha-2 globulin, made by the liver. The text gives it specs, but the important part is it's the inactive precursor to thrombin.
And the liver needs vitamin K to make it properly.
Right. Absolutely essential. Vitamin K is needed for the liver to make functional prothrombin and several other factors. So liver failure or vitamin K deficiency means low prothrombin levels, which impairs clotting and causes bleeding.
And the text describes prothrombin as unstable, easily splitting into thrombin.
Yes. The prothrombin activator complex basically cleaves it to produce active thrombin. Thrombin itself is also a protein enzyme, described as having weak proteolytic capabilities.
Weak may be compared to digestive enzymes, but strong enough for its job.
Definitely. Its main job is the next conversion, fibrinogen to fibrin.
Okay, so thrombin's target is fibrinogen. What's fibrinogen like?
It's another plasma protein also made by the liver. The text notes it's a very large molecule.
Which is why it normally stays inside blood vessels.
Exactly. Its size prevents it from leaking out easily. That's why interstitial fluid, the fluid between cells, normally doesn't clot no fibrinogen. But if vessel permeability increases significantly, like in severe inflammation, fibrinogen can leak out, allowing clotting in the tissues.
So how does thrombin act on this large fibrinogen molecule?
Thrombin snips off a few small peptide fragments from each fibrinogen molecule. What's left is called a fibrin monomer.
And these monomers just stick together.
Yeah, automatically. The text says they have this intrinsic property to polymerize with each other, forming long fibrin fibers within seconds. It's a rapid self-assembly process once thrombin does its job.
Creating the initial meshwork, the sort of scaffolding of the clot.
Right. But the text stresses that, initially, this meshwork is weak. The fibers are held together just by weak hydrogen bonds. It can be easily broken apart.
So it needs reinforcement. This is where that fibrin stabilizing factor comes in, the one from platelets.
Exactly. Fibrin stabilizing factor, also known as factor 13th, is present in plasma but released in larger quantities by the platelets trapped within the clot. It needs to be activated first, though.
Let me guess. Activated by thrombin.
You got it. Thrombin does double duty. It creates the fibrin monomers, and it activates the enzyme that will strengthen the fibrin mesh.
Clever system. So what does activated fibrin stabilizing factor do?
It acts as an enzyme, a transglutaminase, that creates strong covalent bonds between the fibrin monomers and, even more importantly, forms numerous cross-linkages between adjacent fibrin fibers.
Ah, cross-linking. That's the key to strength, turning that loose net into a robust three-dimensional structure.
Absolutely. The text describes the final blood clot as this strong, interlacing meshwork of fibrin fibers trapping blood cells, platelets, and plasma. And crucially, these fibrin fibers adhere to the damaged vessel surfaces, anchoring the clot firmly in place to seal the leak.
Okay, we have a strong anchored clot. What about this clot retraction the text mentioned? What's that about?
Right after the clot forms, maybe within a few minutes, it starts to contract, to shrink. This process continues over the next 20 to 60 minutes. As it contracts, it squeezes out most of the trapped fluid.
And that squeezed out fluid is serum. The text makes a point that serum is plasma minus fibrinogen and most clotting factors. They're used up or stuck in the clot, so serum can't clot.
Correct distinction. And the text emphasizes platelets are absolutely essential for clot retraction. If retraction fails, it strongly suggests a low platelet count.
So the clot doesn't just passively shrink, the platelets are actively doing something.
Very actively. The text explains that the platelets trapped within the fibrin mesh attach to the fibrin fibers. They continue to release factors like more fibrin stabilizing factor, enhancing the cross-linking.
But the contraction itself.
That comes from the platelet's own internal contractile proteins, the actin, myosin, and thrombocytopenia we mentioned earlier. These proteins cause the platelets and the little extensions or spicules they have attached to the fibrin to contract strongly.
So the platelets are like tiny muscles embedded in the fibrin net, pulling it all together.
Exactly. They actively pull on the fibrin strands, compressing the entire meshwork into a smaller, denser clot. This contraction, by the way, is also stimulated and accelerated by thrombin and the calcium ions released from the platelet's internal stores.
So platelets are involved in plugging, providing surfaces, releasing factors, stabilizing fibrin, and contracting the final clot. Busy little things.
Incredibly versatile. And the benefit of retraction. As the clot shrinks, it pulls the damaged edges of the blood vessel closer together, contributing significantly to stopping the leak and stabilizing the repair. Now, something really important for understanding how clots form effectively is the concept of positive feedback.
Right, the idea that once clotting starts, it promotes more clotting, it snowballs.
Precisely. Unless checked, it tends to amplify itself. And the main driver of this amplification, again, is thrombin.
We know thrombin converts fibrinogen to fibrin, but the text says it does more.
Oh, yes. Its proteolytic action affects many other clotting factors in a way that speeds up the whole process.
Like what?
Well, for starters, thrombin can act directly on prothrombin itself, helping to convert it into more thrombin.
Ah, the product stimulates its own formation. Classic positive feedback.
Exactly. And it also strongly accelerates the activity of several upstream factors involved in forming prothrombin activator. The text lists factors 8, 9, X, EL, and 12.
So it speeds up the steps that lead to its own formation. It's accelerating the whole cascade.
Yes, by activating or enhancing the activity of these earlier factors. Plus, thrombin potently stimulates platelet aggregation and release of their factors, further fueling the fire.
So once you get a certain amount of thrombin formed,
the positive feedback loops kick in strongly. More thrombin leads to faster activation of earlier factors, leads to more prothrombin activator, leads to much more thrombin, and so on. It creates this rapid burst of clotting activity.
ensuring the clot grows fast enough and large enough to seal the injury.
Right. This amplification continues until the leak stops, the local factors are consumed, or the anticoagulant mechanisms regain control. Okay, so we know thrombin drives the final steps in amplification, but let's rewind to the very beginning. How was that initial, often rate-limiting prothrombin activator complex actually formed?
The text said it's triggered by trauma to the vessel wall, surrounding tissues, or the blood itself, or just contact with damaged endothelium or collagen.
Those are the triggers. And they activate one or both of two major pathways that converge to form prothrombin activator.
The extrinsic pathway and the intrinsic pathway.
Correct. The extrinsic pathway is initiated by factors outside the blood vessel, typically from traumatized tissue. The intrinsic pathway is initiated by events within the blood itself, like contact with collagen inside a damaged vessel.
And both pathways use a cascade of clotting factors, mostly inactive enzymes activated in sequence, using Roman numerals and A for activating.
Yes, it's like a series of dominoes falling, each activating the next. Let's break down the extrinsic pathway first. It's sometimes called the tissue factor pathway.
Step 1 is the release of tissue factor from the damaged tissue.
Right. Tissue factor, or tissue thromboplankton, is described as a complex of phospholipids plus a lipoprotein component that has enzymatic properties. It's the key initiator here.
Step 2 involves factor X activation. How does tissue factor do that?
The tissue factor lipoprotein complex binds with another clotting factor, factor 7, and requires calcium ions. This entire complex, tissue factor plus factor Holman plus Ka2+, then acts enzymatically on factor X, converting it to its active form, factor Zan.
Okay, tissue damage releases tissue factor, which grabs factor 7, then calcium, and together they activate factor X.
Exactly, it's a very direct activation. Step 3. Factor ZA forms the prothrombin activator. Activated factor ZA then combines with phospholipids, either from the tissue factor itself or from platelets that have arrived, and another factor, factor V, to form the actual prothrombin activator complex.
So the final complex is ZA, factor V, and phospholipids. Is factor V active right away?
Initially, it's mostly inactive within the complex. But as soon as a little thrombin starts being formed, that thrombin rapidly activates factor V.
And the text says activated factor V massively speeds up the whole process.
Hugely accelerates the ability of factor ZA within the complex to cleave prothrombin into thrombin.
Yeah.
So ZA is the enzyme doing the ketting, activated V is the accelerator, and the phospholipids provide the necessary surface.
And there's that feedback again, thrombin activating factor V, which then turbocharges the extrinsic pathway's ability to make more prothrombin activator, leading to more thrombin.
Precisely. The key takeaway for the extrinsic pathway, as the text emphasizes, is its speed. It's described as explosive.
How fast?
Limited mainly by how much tissue factor is released and the amount of factors X, 7, and V available. With severe trauma, the text suggests clotting can begin in as little as 15 seconds via this pathway. It's the rapid response team.
Okay, that's the fast extrinsic pathway triggered by tissue damage. What about the intrinsic pathway? The text says this one starts within the blood.
Yes. Typically initiated by trauma to the blood itself or exposure of blood to an abnormal surface inside the vessel, like exposed collagen when the endothelial lining is damaged. Even contact with glass can trigger it in a test tube.
How does it start? Step 1.
Blood trauma activates factor 12 and platelets. When blood hits collagen or a surface like glass, two things happen simultaneously. Circulating factor 12 gets activated, becomes through 2, just by the contact changing its shape. And platelets adhere to the collagen or surface, become activated, and release their crucial platelet phospholipids, sometimes called platelet factor 3.
So factor 12 activation and platelet activation are the kickoff events here.
Right. Step 2, activation of factor 11. Activated factor 30 then acts enzymatically to activate factor 11, making EXIS. The text mentions this needs high molecular weight kinagen and is sped up by prekallikrein, showing the complexity involved.
Okay, third-aletta activates EXIS.
Step 3, activation of factor 9. Activated factor E enzymatically activates factor 9, making EXA.
We're working our way down the cascade.
Step 4, activation of factor X. This is a really crucial step. Activated factor EGO doesn't activate factor X alone. It needs to team up with activated factor 8 plus those platelet phospholipids and factor 3 from the platelets. This whole complex IGZA activated ECA phospholipids is what activates factor X to factor Z.
And the text specifically flags this step regarding bleeding disorders.
Yes, critically. It notes that a deficiency of factor 8, which causes classic hemophilia A, or a lack of sufficient platelets, thrombocytopenia, makes the step deficient. It bottlenecks the intrinsic pathway's ability to generate factor A's.
So factor 8 and platelets are non-negotiable cofactors for this step in the intrinsic pathway.
Absolutely essential. And finally, step 5. Factor ZA forms prothrombin activator. Once factor A is generated via the intrinsic pathway, it combines with factor V and platelet or tissue phospholipids to form the same prothrombin activator complex we saw at the end of the extrinsic pathway.
Z plus factor V plus phospholipids, the common meeting point.
Exactly. Both pathways are different routes leading to the formation of this key complex, which then cleaves prothrombin to thrombin, initiating clot formation.
So the intrinsic pathway is triggered internally, involves more steps, 12 lemon 9X, relies heavily on factor VIII and platelets at the factor X activation stage.
And the other major difference highlighted by the text is speed. The intrinsic pathway is much slower than the extrinsic one. It usually takes 1 to 6 minutes to cause clotting.
So extrinsic is the fast shock troop response. Intrinsic is the slower, perhaps more sustained reinforcement.
That's a good way to think about it. They likely work together in most real-world injuries. Now, one factor we've mentioned several times, essential for almost all these steps, is calcium ions, Ca2+.
The text makes it crystal clear. Aside from the very first two steps of the intrinsic pathway, factor 12 and XEI activation, pretty much all the other clotting reactions require calcium ions to proceed effectively.
It's a non-negotiable cofactor for most of the enzymatic steps and binding interactions. Without sufficient ionic calcium, blood simply won't clot.
But the text also makes an interesting point about calcium levels in the body.
Right. It says that calcium is so vital for nerve function, muscle contraction, and other critical processes that its level in the blood is very tightly regulated. It rarely, if ever, falls low enough in a living person to significantly impair blood clotting. Other, more life-threatening problems related to low calcium would occur first.
So, while essential biochemically, low calcium isn't a typical cause of bleeding disorders in patients.
Generally not. However, manipulating calcium levels is extremely important for preventing clotting outside the body in blood samples, for transfusions, etc.
Right. How do we do that? The text mentions oxalate and citrate.
Oxalate compounds work by reacting with calcium ions to form an insoluble precipitate, calcium oxalate, effectively removing the calcium ions from solution. The text notes this is effective, but toxic if injected.
Citrate ions work differently.
Yes, citrate doesn't precipitate calcium. It binds strongly to the calcium ions, forming a soluble but non-ionized complex. This effectively hides the ionic calcium so it can't participate in clotting reactions. It deionizes it.
And citrate is preferred for blood transfusion.
Yes, typically uses sodium, ammonium, or potassium citrate. It's valuable because, as the text points out, the recipient's liver normally removes and metabolizes citrate very quickly from the transfused blood.
Releasing the calcium back into the recipient's circulation.
Exactly. So moderate amounts of citrated blood can be transfused safely, assuming the recipient has a healthy liver and the infusion isn't too fast.
But there's a risk if the infusion is too large or too rapid, or if the liver is impaired.
Yes, the text warns about citrate toxicity. If the liver can't clear the citrate fast enough, the citrate concentration in the recipient's blood can rise high enough to bind a significant amount of their own calcium ions,
Lowering their effective blood calcium levels.
potentially to dangerous levels, causing symptoms like tetany, muscle spasms, and possibly even convulsions and death due to calcium's role in neuromuscular excitability. It's a serious concern in massive transfusion situations.
Okay, so calcium is key biochemically, but its manipulation is mostly relevant for ex vivo blood handling using citrate.
Primarily, yes. And to summarize the pathways, after vessel rupture, both extrinsic, fast tissue factor-driven, and intrinsic, slower contact collagen-driven pathways usually get activated simultaneously, working together to generate that crucial prothrombin activator.
All right, we've got a solid handle on how clots form, but just as vital is how the body prevents clots from forming where they shouldn't, keeping blood fluid in healthy vessels. Let's talk intravascular anticoagulants.
This is the crucial other side of the coin, the systems that maintain that delicate balance and stop runaway clotting. The text highlights several layers of defense, starting with the properties of the healthy endothelial surface itself.
The inner lining of the blood vessel. First off, its smoothness.
The sheer physical smoothness is important. It prevents the kind of contact that activates the intrinsic pathway, factor 12 and platelets. Rough surfaces trigger clotting, smooth ones don't.
Then there's the glycocalyx. What is that again?
It's described as a thin layer of negatively charged mucopolysaccharides coating the endothelial cells. The text says this layer actively repels negatively charged clotting factors and platelets, physically preventing them from adhering and activating. like a non-stick repellent coating.
Very clever. And there's another molecule on the surface, thrombomodulin.
Yes, this is a protein bound to the endothelial membrane. It has a specific job. It binds thrombin.
Binds the very enzyme that causes clotting. How does that help prevent clotting?
This is really elegant. Binding thrombin to thrombomodulin does two things, according to the text. First, it effectively removes thrombin from circulation, preventing it from diffusing and causing more clotting. Second, the act of binding thrombin to thrombomodulin actually activates another plasma protein called protein C.
And protein C is an anticoagulant.
A potent one. Activated protein C specifically inactivates two key activated clotting factors, factor VA and factor eta.
The accelerators in the prothrombin activator complex and the intrinsic pathway's factor X activation step.
Exactly. So the endothelium uses thrombin itself via thrombomodulin and protein C to shut down key amplification steps in the cascade. It's a negative feedback loop built right into the vessel wall to limit clot formation.
Amazing. So a healthy endothelium is actively anti-clotting through smoothness, repulsion via glycocalyx, and this thrombin-binding protein C activating system.
Precisely. And conversely, damage to the endothelium destroys these defenses. Loss of smoothness, glycocalyx, and thrombomodulin allows factor 12 and platelets to activate, kicking off the intrinsic pathway. Exposure to the underlying collagen is an even stronger trigger.
The text also mentions other endothelial products.
Right. Healthy endothelial cells also produce substances that inhibit platelet aggregation and promote smooth blood flow. Prostacyclin, PGI2, is mentioned. It's a vasodilator and a powerful inhibitor of platelet sticking.
And nitric oxide, NO.
Also a key player. It's a potent vasodilator and strongly inhibits platelet aggregation. Healthy endothelium makes both. Damaged endothelium makes less, removing these brakes on clotting and vasoconstriction.
The vessel wall is a major player. What about anticoagulants actually circulating in the blood?
The text focuses on mechanisms that remove active thrombin from the blood, as it's such a central enzyme.
First one mentioned is the fibrin fibers themselves.
Yes, surprisingly. As the fibrin clot forms, the fibrin fibers themselves act like a sponge, absorbing about 85–90% of the thrombin generated right within the clot.
So the clot itself helps limit its own spread by trapping the enzyme that creates it.
Exactly. It helps keep the thrombin localized to the injury site, preventing it from escaping into the general circulation and causing trouble elsewhere.
What about the thrombin that does escape the clot?
That's where antithrombin III comes in. It's a circulating plasma protein, an alpha globulin, also called antithrombin heparin cofactor.
And it neutralizes thrombin.
Yes, it combines with any free thrombin that hasn't been absorbed by fibrin. It blocks thrombin's ability to act on fibrinogen and slowly inactivates the thrombin over about 12 to 20 minutes.
So fibrin is the immediate trap. Antithrombin III is the slower cleanup crew for escaped thrombin.
A good summary. And then there's heparin.
The anticoagulant drug. But the text says it's also present naturally.
Yes, but normally in very low concentrations where it has little anticoagulant effect on its own. Heparin is a large, highly negatively charged polysaccharide molecule.
How does it work then?
Its power comes from its interaction with antithrombin III. When heparin binds to antithrombin III, it dramatically increases antithrombin III's effectiveness by 100-fold to 1,000-fold, the text says.
Wow. So heparin supercharges antithrombin III.
Exactly. In the presence of heparin, especially at therapeutic doses, the antithrombin III mediated removal of free thrombin becomes almost instantaneous. The heparin antithrombin III complex also rapidly inactivates several other activated factors, including ISCA, SIGA. So it's thrombin and key factors in the intrinsic and common pathways. Very potent. Where does natural heparin come from?
The text says it's produced mainly by basophilic mast cells, found in connective tissue around capillaries, especially abundant in the lungs and liver. Basophils in the blood also make some.
Lungs and liver. Why there specifically?
The text suggests this is important because these capillary beds receive venous blood where flow might be slower, increasing the risk of small clots emboli forming. Having local heparin production helps prevent these clots from propagating. Okay, we've formed the clot and we've stopped it from spreading uncontrollably. But what happens to the clot once the vessel is healed? It needs to go away, right?
Right, you don't want a permanent blockage. That's the role of fibrinolysis, the process of dissolving the clot.
The key enzyme here is plasmin, also called fibrinolysin.
Plasmin is a proteolytic enzyme, much like the digestive enzyme trypsin. Its main job is to digest the fibrin fibers, breaking down the structural integrity of the clot.
Does it digest anything else?
Yes. The text notes it can also break down other clotting factors like fibrinogen itself, factor V, factor VIII, prothrombin, and factor 12. This means if too much plasmin is activated systemically, it can actually cause a bleeding tendency, hypocoagulability, by depleting clotting factors.
So its action needs to be controlled. How is plasmin activated?
It circulates in the blood in an inactive precursor form called plasminogen, or profibrinolysin. Importantly, a lot of plasminogen gets trapped within the clot as it forms alongside the fibrin.
So the enzyme precursor is built right into the structure it's eventually meant to dissolve.
Exactly. Then, over a period of days following the injury, the damaged tissues and the vascular endothelium slowly release an activator called tissue plasminogen activator, TPA.
TPA, that's the clot buster drug we use clinically.
Yes. The body makes its own version. This naturally released TPA diffuses into the clot and specifically converts the trapped plasminogen into active plasmin, right where it's needed.
And the activated plasmin then gets to work dissolving the fibrin mesh from the inside out.
Precisely. The text highlights this system is crucial for clearing out not just major clots after healing, but also the countless tiny microclots that might form in small peripheral vessels daily. Without fibrinolysis constantly clearing these out, our microcirculation would rapidly become clogged. We see the normal process, the checks, and the balances. Now, let's consider when things go wrong on the other side, conditions causing excessive bleeding due to deficiencies in the clotting system. The text focuses on three main examples.
First, vitamin K deficiency. We touched on this, but let's elaborate.
Right. The liver makes most clotting factors, so severe liver disease obviously impairs clotting, but vitamin K has a very specific role.
It's needed by a liver enzyme, a carboxylase.
Yes. This enzyme adds a carboxyl group, COAH, to specific glutamic acid residues on several key proteins: prothrombin, factor 2, factor 7, factor 9X, factor X, and also protein C, the anticoagulant.
And this carboxylation is essential for them to work.
Absolutely. It allows these factors to bind calcium ions properly, which is necessary for their activation and function in the cascade. Without that carboxyl group, the factors are produced, but they're biologically inactive.
Vitamin K gets used up in this process and needs to be recycled by another enzyme, VKORC1.
Correct. VKORC1 reduces the oxidized vitamin K back to its active form. So a deficiency in active vitamin K or inhibition of VKORC1 leads to the production of inactive factors and thus a bleeding tendency.
Where does vitamin K deficiency come from? The text says diet isn't usually the issue in adults.
Not typically, because our gut bacteria synthesize quite a bit of it. However, it can occur in newborns before their gut flora is established. More commonly in adults, it's linked to malabsorption issues.
Because vitamin K is fat-soluble.
Exactly. So GI diseases that impair fat absorption can lead to vitamin K deficiency. Also, conditions where the liver fails to secrete bile needed for fat digestion and absorption, like bile duct obstruction or severe liver disease, can cause it. Liver disease itself also directly impairs factor synthesis, of course.
The text mentions giving vitamin K injections before surgery in some cases.
Yes, in patients with potential deficiency, like liver disease or obstruction. If the liver itself can still function reasonably well, giving vitamin K allows it to produce active factors within about 4–8 hours, reducing surgical bleeding risk. Okay, next major bleeding disorder, hemophilia.
The classic inherited bleeding disorder, primarily affecting males because it's X-linked recessive.
That's right, the text breaks it down. About 85% of cases are hemophilia A, classic hemophilia, caused by a deficiency or defect in factor 8. Affects about 1 in 10,000 U.S. males. The other 15% is hemophilia B due to a deficiency in factor IX.
Factor 8 and IX, key components of that intrinsic pathway step activating factor X.
Precisely the bottleneck we discussed. Because the genes are on the X chromosome, females usually inherit one affected X and one normal X, making them carriers. They rarely have the full disease unless they inherit 2 affected X chromosomes, which is very uncommon.
Carriers are usually okay, but might have mild symptoms sometimes.
Occasionally, yes. Or females might get a mild form due to rare chromosomal issues or patterns of X inactivation. While mostly inherited, the text notes about a third of cases arise from new spontaneous mutations.
Severity varies.
Yes, depending on the specific mutation and how much functional factor is produced. Bleeding typically follows trauma, but even seemingly minor trauma can cause severe and prolonged bleeding, like tooth extractions.
The text clarified that factor 8 is complex. It's the smaller component deficiency that causes hemophilia A, right?
Correct. The larger component deficiency causes von Willebrand disease, which presents differently. It's that smaller component of factor 8 that's the crucial cofactor with ISO for activating factor X.
Treatment involves replacing the missing factor.
Yes. Infusions of purified factor VIII for hemophilia A or factor IX for hemophilia B. Recombinant versions are now preferred to avoid risks from pooled plasma, but the text notes they are expensive and have short half-lives, requiring frequent treatment,
And the third example of excessive bleeding, thrombocytopenia.
which just means having a very low number of circulating platelets. Normal is 150,000, 450,000 per microliter.
How does bleeding present differently here compared to hemophilia?
The key difference, according to the text, is that thrombocytopenia causes bleeding from small vessels, capillaries, and venules, not usually the large vessel bleeding seen in hemophilia.
Because platelets are essential for plugging those constant tiny leaks.
Exactly. Without enough platelets, these microhemorrhages occur throughout the body, appearing as small pinpoint dots under the skin or mucous membranes called petechiae. This condition is often called thrombocytopenic purpura.
What platelet count becomes dangerous?
The text indicates risk increases below 50,000 pounders, significant bleeding risk after trauma or surgery below 30,000 pounders, and spontaneous bleeding can occur below that. Counts below 10,000 bowels are often life-threatening.
Is there a simple test clue?
Yes, failure of clot retraction. Since platelets drive retraction, a clot that forms but doesn't shrink properly points towards thrombocytopenia.
What causes low platelets?
Several possibilities mentioned. Decreased production from the bone marrow due to infections, drugs, toxins, nutritional deficiencies, cancers like leukemia, or myelodysplastic syndromes. Increased peripheral destruction, often due to antibodies attacking platelets. This is common in idiopathic thrombocytopenia, ITP, where the specific cause isn't always known, but it's often autoimmune. Sequestration, where platelets get trapped in an enlarged spleen. Consumption, where platelets are used up in widespread clotting like DIC, or dilution from massive fluid or blood transfusions lacking sufficient platelets.
So ITP, likely autoimmune destruction, is a major cause.
It's very common. Treatment varies with the cause, but might involve transfusions of platelets for acute bleeding, treatments to suppress the immune system if it's autoimmune, or sometimes splenectomy, removing the spleen, because the spleen is a major site of platelet destruction and sequestration. Okay, shifting gears from too little clotting to too much clotting, or clotting in the wrong place. Let's talk about thromboembolic conditions.
This is when clots form abnormally inside blood vessels. The text defines a thrombus as the abnormal clot itself, sticking to the vessel wall.
And if a piece of that thrombus breaks off and travels in the bloodstream, it's called an embolus.
Where it ends up depends on where it started.
Exactly. Emboli from thrombi in arteries, or the left heart, travel downstream and can block smaller arteries, causing things like stroke if in the brain, or kidney damage.
But emboli from veins or the right heart?
They travel with venous return to the right heart and then get pumped into the lungs, lodging in the pulmonary arteries. This is a pulmonary embolism, PE.
The text describes massive PE as potentially lethal.
Very dangerous. A large clot blocking the main pulmonary artery or both branches can cause sudden death. Even blocking one major branch can be fatal later as the clot potentially propagates or impairs lung function severely.
What causes these unwanted thrombi to form in the first place? Two main culprits.
The text highlights two primary causes. First, any condition that creates a roughened endothelial surface inside the vessel. Things like arteriosclerosis, infection, or physical trauma damage that smooth anticoagulant lining, exposing underlying tissues like collagen, and providing sites for platelets and clotting factors to activate.
And the second cause?
Slow blood flow, or stasis. When blood pools or moves very sluggishly, the naturally occurring procoagulants aren't washed away as quickly. They can accumulate locally, reaching concentrations high enough to initiate clotting, even without severe endothelial damage.
This explains the risk with immobility. The text gives the example of femoral venous thrombosis, or deep vein thrombosis, DVT.
A classic example. Prolonged bed rest, long surgeries, even long flights, or car rides where the legs are still pool. These situations cause blood to pool and slow down in the deep veins of the legs. Stasis allows clots to form there.
And these clots can grow quite large.
Yes, extending up the leg veins towards the heart. The real danger, the text points out, is that a piece of this large DVT can break off maybe 10% of the time.
Become an embolus.
Traveling through the vena cava, right heart, and band lodging in the pulmonary arteries as a potentially fatal pulmonary embolism.
This is where interventions like TPA become crucial.
Yes, the genetically engineered tissue plasminogen activator, TPA. As we discussed in fibrinolysis, TPA activates plasminogen to plasmin, dissolving clots. Clinically, it can be infused, sometimes delivered via catheter directly to the site of a thrombus, like in a coronary artery during a heart attack or a pulmonary artery during PE.
If given early enough, it can dissolve the clot and restore blood flow.
It can be life-saving, especially if given within the first couple of hours for heart attacks or major PEs, limiting tissue damage or preventing death. So given these risks of unwanted clotting, we often need to intentionally interfere with the process using clinical anticoagulants.
To prevent or treat thromboembolic conditions, the text focuses on two main classes used clinically.
Heparin and the coumarins, like the common drug warfarin.
Heparin, we know, works with antithrombin III. It's usually given by injection or 5.
Yes, it's not absorbed orally. The text mentions a typical dose can dramatically increase clotting time, from maybe 6 minutes normally up to 30 minutes or more, and its effect is almost instantaneous when given intravenously.
How long does it last?
Relatively short-acting. The text says 1.5 to 4 hours, as it's broken down by an enzyme in the blood called heparinase. So it's great for rapid short-term anticoagulation.
Coumarins, like warfarin, are different. They're taken orally and work by inhibiting VKORC1, right?
Exactly. They block that enzyme needed to recycle vitamin K back to its active form in the liver.
Leading to decreased production of active carboxylated prothrombin, factor 7, factor 9X, and factor X in protein C.
Right. The liver still makes the proteins, but they're inactive without that vitamin K dependence step. Importantly, though, the text stresses that the effect of warfarin is delayed.
Because the already circulating active factors need to degrade naturally first.
Precisely. It takes time for those factors to be cleared and replaced by the inactive ones being produced under warfarin's influence. Clotting ability decreases gradually, maybe 50% reduction after 12 hours, 80% after 24 hours. It's not instant like heparin.
And the effect also wears off slowly when the drug is stopped.
Yes, it takes 1 to 3 days for the liver to synthesize enough new active factors once vitamin K recycling is restored. This slow onset and offset make warfarin suitable for long-term anticoagulation, but requires careful monitoring using INR to maintain the right balance.
What about preventing clotting outside the body? For lab tests, transfusions, medical
The
devices,
text covers this too. The surface the blood touches is important.
glass triggers clotting.
Yes, glass activates factor 12 and platelets, intrinsic pathway, so blood clots in about 6 minutes. But coating the container with silicone prevents this contact activation, delaying clotting for an hour or more. Careful handling is key.
Can heparin be used?
Yes, heparin can be added to blood collected for use in machines like heart-lung bypass or dialysis machines to prevent clotting in the external circuit.
But the most common method involves calcium manipulation.
Usually, either using oxalate to precipitate calcium, toxic if injected, or, more commonly for blood going back into a patient, using citrate to deionize the calcium.
We covered citrate's mechanism and the potential risks of citrate toxicity with rapid large transfusions or liver failure, but generally safe otherwise.
Correct. It's the standard for blood banking and transfusion because it's effective ex vivo and normally well tolerated in vivo.
Okay, so how do we measure how well this whole system is working? Let's talk about blood coagulation tests.
These are crucial for diagnosing bleeding or clotting disorders and monitoring anticoagulant therapy. The text describes a few key ones.
Bleeding time. Sounds simple.
It is, relatively. A small standardized puncture is made, finger or earlobe, and you time how long it takes for bleeding to stop. Normal is 1 to 6 minutes, per the text.
What does it mainly test?
While affected by several factors, the text notes it's particularly sensitive to platelet function and number. A prolonged bleeding time strongly suggests a platelet problem.
Clotting time. This is the one in the glass tube.
Yes. Timing how long it takes for collected blood to clot in a standard glass tube. Normal is 6–10 minutes. The text mentions it's quite variable and less used now, replaced by more specific factor assays.
The big one seems to be prothrombin time, PT, and the related international normalized ratio, INR, especially for warfarin monitoring.
Absolutely central. The PT test assesses the integrity of the extrinsic and common pathways.
How's it done?
You take the patient's blood, prevent it from clotting using oxalate or citrate, which binds calcium. Then in the lab, you add back an excess of calcium ions to overcome the anticoagulant and a standardized amount of tissue factor.
Tissue factor specifically kicks off the extrinsic pathway.
Right. Factor 7 gets activated, then X, then prothrombin activator forms, converts prothrombin to thrombin, and fibrin forms. The time it takes from adding calcium and tissue factor until the clot forms is the PT.
Longer time means slower clotting, possibly low factors or inhibition.
Exactly. Normal PT is around 12 seconds. A longer PT suggests deficiency in factor 7, XV prothrombin, or fibrinogen, or inhibition by something like warfarin. Labs use calibration curves to relate PT to factor activity.
But PT results used to vary a lot between labs.
Yes, due to differences in tissue factor reagents and instruments. That's why the International Normalized Ratio, INR, was developed.
How does INR standardize it?
It uses a mathematical correction. Each batch of tissue factor reagent is assigned an International Sensitivity Index, ISI, by the manufacturer, comparing its activity to a global standard. The INR is calculated as patient's PT mean normal PT raised to the power of the ISI.
This gives a standardized number regardless of the lab or region.
Correct. A healthy person's INR is typically 0.9, 1.3. High INR, Regate 4 to 5, means high bleeding risk. Low INR, Ag 0.5, might suggest clot risk. For warfarin therapy, the target INR is usually 2.0, 3.0, representing a safe level of anticoagulation.
Can we test other specific factors?
Yes, using similar principles. To test, say, factor VIII, you would take the patient's plasma, add calcium, tissue factor, and a region containing all other clotting factors except factor VIII. The time it takes to clot, then, depends specifically on the amount of factor VIII in the patient's sample. Deficiency prolongs the time. And just to close the loop on the 4 original hemostasis mechanisms, let's briefly revisit the final step: fibrous organization for permanent repair.
This is the long-term healing part, after the immediate bleeding has stopped.
Right. The text explains that within hours of the clot forming, fibroblasts, cells that produce connective tissue, start migrating into the clot. This invasion is encouraged by the growth factor released from those trapped platelets.
Those platelets again, involved right to the end.
They really are. Over the next 1 to 2 weeks, these fibroblasts lay down collagen and other connective tissue fibers, gradually replacing the clot material.
Turning the temporary fibrin clot into permanent fibrous tissue.
Exactly. It becomes organized into scar tissue that permanently seals the vessel defect, integrating into the vessel wall. This is a typical outcome for a clot that served its purpose in stopping bleeding. Clots formed elsewhere, or excess clot, are usually dissolved by fibrinolysis instead, so we've covered a huge amount of ground there. From that immediate vascular spasm
Through the quick platelet patch.
to the incredibly complex cascade of coagulation building that strong fibrin clot.
It's retraction, tightening the seal.
And finally, the long-term fibrous repair, or the equally important clot dissolution by fibrinolysis. It's an amazing system.
Truly elegant. The level of detail, the checks and balances between clotting and anti-clotting, it's mind-bogglingly complex, but usually works perfectly.
And understanding the key players, thrombin, fibrin, platelets, calcium, vitamin K, the different factors, the pathways, the inhibitors like antithrombin, the protein C, the clot busters like TPA, it gives you that deep appreciation, the kind needed to really master this field.
Absolutely. Going through these mechanisms step by step, I think we've definitely moved beyond surface knowledge into a much deeper understanding of this vital process.
So here's something to ponder. We've seen how tiny molecular interactions, an enzyme activation, a missing cofactor like vitamin K, the stickiness of a platelet, the presence of an inhibitor underpin these massive physiological outcomes, like stopping life-threatening bleeding or causing a fatal embolism.
Right, small changes, huge effects.
What other biological systems operate on such knife-edge balances where seemingly minor molecular details or single protein functions have such profound system-wide consequences for health and disease? It makes you appreciate the incredible precision engineered into our biology.
Definitely food for thought. Until our next deep dive.